Chapter 3, The Home for the Dying. La vie c'est boucante misère pour traquer. In this life, one trades misery for trouble. Haitian proverb. Saint-Fith was a most depressing place. It was here that the best the human race had to offer, the sisters, cared for the products of the worst conditions the human race could produce, the patients. They found them lying in gutters, crawling in garbage dumps, thrown into the depot, or dropped off at the front door. They were the handicapped, the elderly, the retarded, and the abused. They were prostitutes with AIDS, men beaten by the tonton macoutes, and disease-infested skeletons breathing their last breaths. The sisters did not delude themselves into thinking they could help everyone at Saint-Fith and had appropriately named it the Home for the Dying. They saw these patients no differently from the way in which personnel in the growing hospice movement view those with metastatic cancer or progressive senility. They were to be kept comfortable and loved and die with a smile on their face. Nonetheless, the sisters wanted to cure those with treatable diseases. They distributed medicine, gave intravenous solutions, and kept records. Unlike most missions in Haiti, the missionaries of charity had plenty of equipment. Generous doctors sent everything: intravenous solutions, bandages, sutures, vitamins, medicines, crates upon crates of them. Frequently, I had to take time away from patient care to help the sisters figure out what to do with this plethora of equipment. Even the Haitian government did not dare block the flow of medical supplies to Mother Teresa's order. I was helped at Saint-Fith by Day and Nick. Day had just graduated from Brown University and opted to spend a year in Haiti before entering medical school. A muscular former college wrestler, he had short blonde hair, blue eyes, a square jaw, and a bull neck. Even the environment could not hide his preppiness. When he wore his green boxer shorts, he grabbed the matching green stethoscope. I always teased him. I told him he should be doing milk commercials or posing for cornflake boxes. Nick was a college student from England and a dead ringer for Errol Flynn. Good-natured and gregarious, he was unsure of his future plans, but was considering joining the priesthood. I had given them a crash course on how to be a doctor. I taught them the physical exam, treatment of common diseases, and basic procedures. They did spinal taps and thoracentesis, draining fluid from the chest, which are procedures performed only by physicians in the United States. They instinctively grasped everything I showed them, but more important, they cared. They cared enough to learn Creole in a matter of weeks, something American foreign affairs personnel rarely bothered to do. I constantly relied on their judgment. I made rounds at Saint-Fith in the early afternoon when the temperature topped 100 degrees. Irate after just escaping death at the hands of the tap-tap drivers on Rue Delmas, I would be tempted to forego rounds until I saw my favorite patient, Kosa Mala. Kosa guarded Saint-Fith. Daily I asked him, Sac passe, what's happening? Kosa Mala, he responded with a distant look of terror. Thus he was named Kosa Mala, Spanish for bad thing. Many Haitians speak Spanish because they have worked in the Dominican Republic cutting sugarcane or constructing roads, low-paying, back-breaking work that the Dominicans refuse to do even though their unemployment rate is 30%. Kosa Mala did little more than exist. Crippled from the contractions of his leg flexors, he could only propel himself by a crab-like walk. His thick, wide forehead protruded over his vacuous eyes. As he rambled incoherently, his broad nose flared and his open mouth revealed fiery, inflamed gums that suspended his black, cavity-infested teeth. Occasionally he sat on a chair, but he preferred the concrete floor. His drooling saliva attracted flies he had no interest in dispersing. The other patients treated him as a pet rather than a human being, and I was embarrassed to admit that I found myself doing the same. I never figured out what was wrong with Kosa Mala, but my instincts told me he was once a normal, functioning human being who had suffered a tragedy. Perhaps the scars on his head were the result of a beating that left him permanently brain damaged. Maybe he had suffered from brain-damaging meningitis. Then again, it was possible he was simply psychotic. When I walked over to him, he would stare at me and plead, Amwe, help, help. Cosamela's needs were very basic. He wanted either food or a cigarette. He could devour a huge bowl of rice in minutes, licking the bowl completely clear. I always gave him a cigarette, seeing little sense in denying him his greatest pleasure in order to prevent diseases he would not live long enough to develop. He would inhale deeply, holding the nicotine and charcoal in his lungs as long as possible, savoring the taste before expertly ejecting the smoke out through his nostrils. His enjoyment was sensual and would have been a persuasive advertisement for cigarettes. Attempts to cure or rehabilitate Cosamela were fruitless. One red-hot internist, fresh from his residency at the Mayo Clinic, treated him for the entire gamut of reversible dementias with penicillin, vitamin B12, thiamine, and other assorted concoctions. Others tried to teach him to walk, stretching his fused tendons until tears came to his eyes. I did not discourage these efforts, since I had made similar futile attempts. But every day when I asked "Sac passe," he responded "Cosamela" with a distant look of terror. Cosamela was an example of someone who simply needed a place to live, a permanent fixture at Saint-Fith. As time passed, I learned those patients I could help and those I could not. However, acquiring this judgment was the most emotionally draining experience I had in Haiti. As any other physician would do, I began by erring on the side of over-treatment. In doing so, I became depressed as I realized my limitations. Many patients were going to die regardless of my diagnostic acumen and intervention. One of the first to teach me this hard reality was Teresa Lewis. She was a bedridden 20-year-old woman who had diarrhea. She desperately clutched at my arm and implored me to save her. Yet she had the look of someone who was dying and knew it, a look every physician learns within weeks of beginning internship. Her mouth was parched, her eyeballs sunken, and her systolic blood pressure 60. She was severely dehydrated, so I placed a large bore intravenous needle in her arm, and within an hour had given her a liter of fluid. Her blood pressure increased to 80, but she appeared the same. I figured that when her diarrhea stopped, she would improve. It never stopped. I tried everything. I pored over her stool specimen with my microscope, observing the multitude of worms and protozoa that flourished in her intestine. I read and reread my tropical medicine textbooks, weeding through the verbiage for the single sentence that would save her. I never found it. Her case became my obsession. I tried antibiotics, antiparasitics, antimalarials, vitamins, and anti-tuberculosis medicines. The diarrhea still flowed. Thinking her problem might be polypharmacy, too many medicines, I stopped everything, and the diarrhea still flowed. "Dr. J, bon me lave. Dr. Joe, give me life," she pleaded. But she slowly worsened. Here was a woman younger than I, dying. Soon she refused intravenous fluid, wisely observing that it increased her diarrhea and made her body swell. If she lay on her left side, only that side swelled, giving her a macabre appearance. I did not know what to do, and there was no one to ask. She could not absorb any food because she was too malnourished to regenerate the villi in her intestine. She was malnourished because she could not absorb food. One day, she gave up, refusing to eat or take medicine. At this point, I gave up too. Eventually, she succumbed, unaware that her agony had contributed to my medical education. Soon, I learned how to triage. In the first group were those like Cosamela, who just needed a place to stay. Like the grandparents deposited in the hospital where I interned so that their families could vacation, this group needed no medical care, only food and human contact. As a matter of fact, treating these people made them worse. The second group was those who were dying. As my experience increased, so did the number of patients in this category. Initially, my assessment was based on concrete data: blood pressure, heart rate, muscle mass, and respiratory patterns. The sisters had a more accurate way of predicting death by counting the number of flies hovering above the patient. As the patients faded, the flies came, swarming over their faces and feasting on their excrement. Those who were strong enough covered themselves with sheets, but the severely debilitated had to tolerate them. Evelyn was such a patient. She was an elderly woman who just wanted to die in peace. When I saw her, she was lying under a blanket with her hands, white from anemia, covering her face to protect her from the flies. She was ancient, at least 80 years old. Her wrinkled forehead gave way to thin, dark eyebrows, underneath which her eyes, the pupils opaque from cataracts, attempted to discern me. She was toothless, and her lips rolled inside her mouth so that the vermilion border was invisible. The other women braided her short gray hair so that she had the appearance of a horned owl. Her face did not look as if it possessed the wisdom of the ages, only a semi-content look of satisfaction. She was a survivor. She had survived numerous childbirths, batterings from sexually aggressive, belligerent men, the American occupation, Papa Doc, and the Tonton Macoutes, but she was resigned to accepting her destiny. I gently lifted the blanket in order to examine her. Around her neck were rosary beads, arcing over her collarbone and tracing the contours of the crevices between her prominent ribs. The flesh on her back was sculptured by her vertebrae, and the scapula, 2 triangles below her shoulders. Her taut skin stretched over her pelvis, showing the architecture of this complex bone as it curved to form the pubis under which all her children had passed. She had probably outlived them all. Her legs were spindles. Unable to verbalize her objection to my rude interruption, she defecated, unabashed by her state, not wanting to be cleaned, only to be left alone, to die and meet whatever deity she believed in. After seeing patients like Evelyn day in and day out, I began to wonder what I was doing in Haiti. It was beyond my comprehension that people could be subject to such misery. What had they done to deserve this? I could see no value in their suffering. Many were so young, younger than I, yet I could not save them. Slowly, I began to accept my limitations. With dying patients, my job was to comfort, not cure. Historically, this has been the role of the physician. It is only recently that effective treatments have been found for heart failure, asthma, syphilis, and tuberculosis. The potions used to treat these diseases at the turn of the century were useless and often dangerous as well. With the sisters' help, I mastered the art of caring for the dying so that patients like Evelyn could die with dignity, with a smile on their face. The sisters kept the dying clean and fed those who had the energy to swallow. I did my best to see they were comfortable. One of my first actions was to cover the dying patients with mosquito nets. The problem was that Saint-Fille had no air conditioning, and some patients preferred the persistent flies to the choking heat under the nets. Flies did not cause the visceral revulsion in Haitians that they did in me. At times, I thought I was just treating myself. Also, the Haitians, perceptive people, realized that when I covered someone with a net, I expected that patient to die. One even yelled at me, "Me pap mori! I'm not dying." She was wrong. Although empathy and compassion were important, they were not always enough. No amount of hand-holding and tender, loving care could comfort patients who were in their early 20s and dying. They were being cheated, and they knew it. These patients and those with intractable pain needed something more. With liberal doses of Valium and Demerol, I was able to comfort them. I would add these drugs to the intravenous solutions so that they received a constant infusion, since neither the sisters nor I had the time to constantly administer them. We had the eternal gratitude of these patients. Even an intravenous solution by itself can be comforting. Dying patients do not have the energy to drink and become dehydrated, an unpleasant state, as anyone who jogs or plays tennis can testify. I will never forget one patient who was brought to Saint-Fille. About 50 years old, he weighed 65 pounds. The retracting facial skin taut on his skull made his beard look even more straggly. It did not take an infinite amount of wizardry to see that he was dying. Since he was severely dehydrated, I immediately placed an intravenous line. Even though I have started thousands of intravenous lines, it took me several attempts because his veins perforated so easily. When I was done, I stood up beside his bed. He did not even look at me, but sensing that I had finished the procedure, he reflexively said in perfect unaccented English, "Thank you, have a nice vacation." Later that day, he died. My third triage group was the treatable. These were the ones with which I spent most of my time. Here is where I could make a difference by catching a reversible problem before it progressed. One woman was brought to Saint-Fie after she was found lying on the street of one of the slums. The Belgian priest who brought her told me that her husband got tired of listening to her whining and heaved her out of their house. Teresa Pierre was exhausted and weak. Dressed in a tattered blue dress with a red bandana tied around her head, she was a handsome woman of 20 with high cheekbones, robust lips, and piercing black eyes. She did not appear malnourished. One thing I learned in Haiti is that a well-nourished patient who is acutely ill is often someone I can cure. I extracted from her that she had mal-tête et la fièvre, headache and fever. In Haiti, this is malaria until proven otherwise. However, upon examining her, I found her neck was so stiff that when I tried to lift her head, it elevated her upper body. She refused to bend her neck. In medical parlance, this is called nuchal rigidity and is seen in meningitis, an infection of the lining that encases the brain, spinal cord, and spinal fluid. Without treatment, it can be fatal, and those who survive may have neurological damage such as paralysis, deafness, or impaired mental capacity. The diagnosis is easily made by doing a spinal tap. Since this lining space, the meninges, extends past the termination of the spinal cord, one can take out spinal fluid by inserting a hollow needle with a stylet in between the vertebrae in the lower back. To the uninitiated, it's a terrifying procedure. The patient must curl up in a fetal position while a 5-inch needle penetrates the back. With proper anesthesia, there is little pain, but the idea of a needle impaling one's back is emotionally disconcerting. Teresa Pierre voiced no objections as I positioned her. Being trained to always explain procedures to my patients, I informed her in simple Creole what I was about to do. She was so lethargic that she did not even cry or move as I plunged the large needle 4 inches into her back. Feeling the characteristic pop as I entered the meningeal sheath, I pulled out the stylet. Several drops of cloudy fluid dripped out. Spinal fluid should be clear. Quite excited, I examined the fluid under my microscope. There were numerous white blood cells along with rare gram-negative rods clinching the diagnosis. After searching through several boxes in our hopelessly unorganized dispensary, I found the same antibiotics I would have used in the United States, ampicillin and chloramphenicol. Of course, they were expired, but beggars cannot be choosers. The medicine must be given in a vein, so I put an intravenous line and gave the first dose myself. 2 days later, she did not seem much better as she lay there burning with fever, barely responsive. She had one good sign, however. When I restarted the intravenous line, she quickly arose from her somnolence, screeching, "Ooh-yee!" Nonetheless, I wondered if she was receiving the proper antibiotics. I never knew what type of bacteria was causing the infection. In the United States, the lab would not only identify it, but also tell whether it was sensitive to the antibiotics being used. Here, I just guessed and prayed. The most difficult part about her care was keeping the intravenous line in her arm. Every day when I arrived, it was out. The sisters were busy enough as it was, though they could not do everything. So daily, against her objections, I restarted it, and gradually she improved. After a week, the fever stopped, and figuring I could cut corners, I switched her to oral antibiotics. Meningitis should be treated with intravenous antibiotics for at least 10 days, but this was Haiti. There was no attending or chief resident to tell me I was not following the accepted protocol. It was a mistake. The next day, she spiked a fever. Cursing my stupidity, I restarted the intravenous line. Fortunately, the gods were kind and forgave me. She again improved, developing the key sign, an appetite. She never understood why she needed the intravenous line, screaming every time I placed it, as if I were some sort of torturer. I tried to explain to her many times why she needed it, but she did not understand. She was an illiterate, superstitious peasant who had barely been conscious when she arrived. Now she was slowly improving, but was being told by this crazy Blanc who spoke the strangest Creole that she needed a needle in her arm, and it made no sense to her. But I was not going to make the same mistake twice. Like it or not, she got the intravenous medicine every day until I was satisfied that the meningitis was eradicated. One day I walked into the woman's ward, and she was standing there washing dishes. Since she was better, the sisters had put her to work. She gave me a huge smile, saying, "Bonsoir," good afternoon, realizing that all of my torture had cured her. Eventually, she departed, healthy, thanking me profusely. The Haitians are very appreciative people, even if they are not sure about what you are doing. Another reversible problem I treated was heart failure. Joseph, a young man brought from the depot, suffered from shortness of breath. In the United States, this is either asthma or pneumonia, but when I listened to Joseph's lungs, it was obvious he had neither. I heard extra sounds called rales, caused by extra fluid that had collected in the lung spaces. When the left side of the heart pumps poorly, the fluid backs up in the lungs and the patient cannot breathe. In older patients, heart failure usually occurs because a previous heart attack has weakened the muscle or high blood pressure is making the heart work too hard. In young patients, it is congenital, caused by either a malfunctioning valve or a hole in the wall between the chambers. In the third world, there is another cause, thiamine deficiency. Thiamine, one of the B vitamins, is ubiquitous in nature, but there is not much in sugar cane, which is all poor Joseph sucked on. Without thiamine, the heart muscle contracts inefficiently. Joseph, good-natured and optimistic, did well. I gave him a mild diuretic, allowing him to slowly lose the excess fluid. Meanwhile, I gave him megadoses of intravenous thiamine. It took time, almost a month, but eventually Joseph was breathing comfortably. Many patients at Saint-Fils came from the depot, a walled-off area beside the general hospital. Here the rejects from the hospital were strewn on the ground, dying, insolvent, and too weak to move. In spite of the conditions, there is a communal atmosphere. Those able to walk care for those who cannot. Men non l'enfer, Jean mun pas. Even in hell there is friendship. Along the walls are stacks of cardboard, which are spread out at night to sleep on. Food, usually a small bowl of rice, is distributed twice a day. Unlike the rest of Haiti, no one here asked me for anything. They knew their situation was hopeless. They were beyond begging. Actually, the depot's condition has improved since the sisters received the government's permission to make it habitable. The piles of garbage that attracted monstrous rats have been removed. Those brought to Saint-Fils no longer have gnawed holes on their faces. The new drainage system presents flooding during tropical deluges so that these too feeble to move no longer drown. During my stay in Haiti, I came to know the depot well. Everyone there came to know me too. Many patients I had cured would arrive there 3 months later with another problem, usually stemming from malnutrition or homelessness. The first depot patient I encountered was a young man lying on the ground. The Tonton Macoutes had beaten him with their favorite weapon, a club with a protruding nail. His crime was organizing a bourlette, or lottery, Haiti's national pastime. The Haitians, like most poor, are fanatical gamblers. As the proverb goes, si ou pas jouer, ou pas ka gagner. If you don't play, you can't win. They put their fate in the hands of their gods. I suspect his real crime, though, was not making large enough payoffs to the tontons. Well-nourished and muscular, he was not a typical depot patient. Until the gods had frowned on him, he had been prospering by Haitian standards. Between the sinews of his thigh, a large abscess had formed around one of the puncture wounds. Its pain had made him an invalid. He greeted me with a warm smile. He knew I was there to help. There was no fever, but the lymph nodes in his groin above the abscess were swollen. Lymph nodes are glands that fight an infection in an area they drain. This is the reason they may swell up in the neck during a sore throat or a cold. The sisters took him to Saint-Fils. There, after giving him a local anesthetic, I made a large cut with a scalpel into the abscess and drained all the pus. We gave him penicillin injections, and soon he was walking without pain. After several weeks, he departed a wiser man, more willing to allow the tontons to extort from him. Depot patients could be helped if someone only took the time. Gratifying as it was to cure people, I was just scratching the surface. Making someone healthy was easy when compared to making survival possible in a brutal country like Haiti. Sanfi was a reprieve from reality, a chance to regain health before facing a hostile world. Many of our patients simply could not make it. Louis was a classic example. He arrived at Sanfi gaunt, febrile, and coughing from tuberculosis. 2 months later, the tuberculosis was under control. He had gained 30 pounds and was confident that he could now make a living. There was a problem, however. He had no place to go. Undaunted and sporting a huge smile, he left anyway, thanking all of us for helping him. His only possessions were a snapshot of himself taken by a generous visitor, a Liberty Bowl t-shirt, trousers, and a Minnesota Twins baseball cap. 2 days later, he was back. Day found him lying at the front door, tears streaming down his face, clutching his now tattered picture. Day was prepared for anything. He was used to Haiti. Louis's shirt was filthy, the trousers torn, and the cap long gone. His eyes were sunken deep into his head, and he had lost at least 5 pounds. He could barely respond to my questions. Do you have a family? No. Friends? No. Did you have a place to sleep? No. Where did you sleep? Under the tables in the marketplace with the crazy people. Did you eat anything? No. Did you drink anything? No. There was no way he could survive in the real world of Haiti. This is why so many roamed the streets begging, looking for cars to clean, trying to do odd errands, or becoming prostitutes. It was that or nothing. Many Haitians could not get enough money together to buy food or rent a place to sleep. They forever roamed around until some social organization helped them, or more commonly and tragically, they lay down and died. Day made Louis some Kool-Aid. He did not have the strength to sit up, so I helped him. Now the tears really began to roll down his cheeks. As he gulped down the Kool-Aid, he said nothing, not even merci. He was embarrassed and depressed. His pride was shattered and his self-esteem non-existent. He did not like being dependent on us. He returned when he felt the only alternative was death. Medically, he was fine, but now he had a greater problem. Uneducated, illiterate, with no marketable skills, he had no earning power. To help him would require a huge investment. Someone had to pay his room and board while he learned a trade. There were hundreds of thousands like him. As I watched him weep, I realized how little I could change. I could cure tuberculosis, malaria, and dysentery, but I could not cure the disease of living in Haiti. This scenario was repeated ad nauseum. The same thing happened to the women, the only difference being that upon returning, they were also pregnant. Though I was discouraged, I felt I was acquiring the skills to render good medical care. However, the minute I got cocky was the minute I got burned. A teenage girl, Caroline, complained that her legs hurt, especially when walking. With her high cheekbones, neatly braided hair, and impeccable posture, she appeared healthy, with only a tinge of anemia in her skin. I examined her carefully, checking her muscular legs for atrophy and tenderness. Using my knuckles, I no longer carried a hammer, I checked her reflexes. Everything was normal. Her hips functioned, since I could elevate each leg until it formed a 90-degree angle with her torso. She could bend her knees and rotate her ankles. Yet she persisted with her complaint. I had her walk, watching her grimace with each awkward step. She was either in considerable pain or a good actress. Compulsively repeating my examination, I again found nothing until I touched her right knee. It felt hot. How did I miss this the first time? Sensing pay dirt, I pushed on her patella, the kneecap. Rather than meet resistance as it opposed the knee bones, it balloted in a sea of fluid that should not be there. Humbled once again, I grabbed a syringe to extract the fluid. I explained the problem to her. Rather than dismay, her cherubic smile indicated relief that I finally believed her. I stuck the needle in between the patella and the knee bones, withdrawing clear yellow fluid. Joint fluid aids in determining the cause of a swollen joint. An infected joint has cloudy white fluid with many white blood cells and bacteria. In gout, one may see crystals. By putting a drop of fluid between the thumb and forefinger and rapidly separating them, one can get a crude idea of its viscosity. Non-infected fluid is viscous, so that a string is formed. The string test is now regarded as hopelessly misleading, which it is, but in Haiti I needed all the help I could get. Caroline's joint fluid formed a 5-inch string. Under the microscope, there were no crystals or bacteria, only a few white blood cells. She had a non-infected joint. I asked her more questions and examined her for the third time. She did not fall on her knee, but volunteered that her hands were stiff, especially upon waking up. She also had fluid in her left elbow. Even with this crude assessment, I had enough information to diagnose rheumatoid arthritis. She had the juvenile variety, which is common but does not receive much publicity. Patting myself on the back, I came up with a brilliant treatment: aspirin and thyme. In spite of its simplicity, the treatment worked, and Caroline was soon walking normally. It did not stop her from complaining, however. Some of her complaints, such as worms crawling out of her mouth, were legitimate. She had reminded me that medicine is a humbling profession. There are no professors, just students at different stages of advancement. The Haitians also taught me some of their medical treatments that were often more effective than mine. One time I witnessed a woman go into intense mourning after her child succumbed, writhing on the floor, contorting her face, thrashing, kicking, and screeching. The sisters looked at me, waiting for me to do something. I drew up a syringe of Valium and prepared to inject her, but she was moving so much that I was afraid a blind stab would injure her. I had no choice but to stand by and prevent her from hurting herself. Fortunately, a Haitian woman came to my assistance. She lit a match, blew it out, and then applied the ashes to the mourning woman's scalp. Then she tied a small square knot with the woman's hair over the ashes. The writhing stopped, and this previously wild woman stood up and walked away as if nothing had happened. Several months later, in the woman's ward, I was again faced with a patient reenacting the same scenario, which the Haitians incidentally called a crise. Not being an American medicine chauvinist, I lit a match, extinguished it, rubbed it on the woman's scalp, and tied her hair over the ashes. Her crise desisted, and I proudly went on to my next patient while registering a new treatment in my armamentarium. Although Haiti is replete with malnutrition, tuberculosis, and dysentery, it also harbors bizarre tropical diseases. The sisters brought one such case to Saint-Fils. When I first saw him, he was sitting in a chair wearing one of the donated gowns. He was middle-aged, graying, and balding, and did not appear to be in any distress. "Que problème ou? What is your problem?" I asked. He did not reply verbally, but dramatically lifted his gown, revealing to my horror a scrotum the size of a basketball, a huge sac stretched to a size beyond imagination. He could not walk without placing a towel beneath his scrotum and suspending the weight with his hands. One of the sisters put it best when she remarked that she did not understand why God created such a terrible disease, wondering how this kind of suffering could possibly help this man. I had seen pictures of the problem in textbooks and knew the diagnosis, since pictures like this are not easily forgotten. It was filariasis, a parasitic disease that is spread by mosquito bites. Immature forms of the parasite filariae enter the bloodstream, are carried throughout the body, and eventually lodge in a lymph node. Here, the filariae mature and reproduce, destroying the node and causing the area it drains to swell. This poor man was unfortunate enough to have the lymph nodes that drained his scrotum destroyed. It can affect other areas too. One of my patients had his leg so swollen that the skin became redundant and folded over itself, making his leg look like that of an elephant, a condition appropriately named elephantiasis. Another patient had a clitoris the size of an orange. I told this man I would try to help him. He quickly responded, "Upa cap aide, masamem bonje cap aide me." You can't help me, only God can help me. He was right. Once the lymph nodes were damaged, nothing could be done. However, medicine could prevent the filariasis from progressing. The medicine also chased the filaria into the bloodstream before killing them, providing a method for making a positive diagnosis via microscopic examination. Thus, I could check anyone for filariasis. Day and Nick knew enough to obtain a blood sample on anyone who had unilateral leg swelling. If I saw the serpentine filariae winding amidst the blood cells, we would give medicine for several weeks, preventing our patients from developing serious physical handicaps. Although this patient was skeptical about my ability to help him, he did allow me to take his picture. When I first arrived in Haiti, I took pictures of everyone, even people on the street. The Haitians did not appreciate this, and after several months in the country, I realized how rude I was. I would not like it if someone driving a Jaguar and wearing a Bijon suit stopped and took pictures of me while I was working and minding my own business. Upon realizing this, I asked permission before taking pictures and then negotiated a fair price. When I got to the point where I thought nothing would surprise me, I would see something more bizarre than ever before. Some Haitian nuns brought in a comatose man they had found lying in front of their convent. They carried him out of their car and placed him on the concrete floor in front of the men's ward. Only his nose rose above the sea of flies that immediately alit upon his face. They filled his eye sockets, crawled in and out of his nostrils, and were dispersed by the foaming saliva that bubbled from his lips with each labored breath. The saliva dribbled down his chin and neck, reaching his heavily stained t-shirt. Along its trail, the flies jockeyed for position. Although I was hardened, this sight tested my digestive system. I felt my avocado lunch shoot up my esophagus. It did not prevent me from making the diagnosis. He had rabies. Virtually non-existent in the United States, rabies is uniformly fatal unless treated early. It progresses through several stages, the most notable being the rabid stage, characterized by paroxysms of violence. Eventually, the patient slips into a coma and succumbs. There was nothing to be done for this poor man, and he soon died. His image popped into my mind every time dogs chased me while I was riding my moped through the streets. Although I saw more exotic disease in Haiti than in the United States, my main job was still nuts and bolts medical problems. One of these was ascites, a collection of fluid in the abdomen. At any given time, it affected half a dozen patients in Saint-Fith. A patient with massive ascites looks as if he's pregnant. The skin over the abdomen is stretched tautly from the pubic bone to the bottom of the rib cage, giving it an iridescent sheen. The fluid pressure causes the umbilicus, the navel, to pop up, making the abdomen appear as a gently rounded hill with an observatory on top. Mild ascites is harder to diagnose because it looks just like a pot belly. Since this was not a possibility in Haiti, anyone who had a distended abdomen had ascites until proven otherwise. I could confirm it by performing one of the lost arts of physical diagnosis, percussion. In percussion, one places a finger flat on the skin and taps it with the index finger of the opposite hand. By the sound this makes, one can ascertain the nature of what is under the skin. If it is air, one hears tympany, but if it is fluid, a dull thud emanates. By percussing across the abdomen with the patient supine, one can determine where the air meets the fluid by hearing the sound change. If the point changes when the patient lies on his side, it is called shifting dullness, a good indicator of ascites. Since X-rays and ultrasound are much more accurate, percussion is rarely done properly in the United States. The treatment of ascites is a mild diuretic and bed rest. The key is to remove the fluid slowly to avoid dehydration. A problem arises in a patient with massive ascites since the fluid impinging on the diaphragm gives the lungs less room to expand, resulting in shortness of breath. In this case, the fluid must be removed directly by draining it from the abdomen. It's a simple procedure. It can be done safely by using an angiocath, which is a needle with a surrounding plastic catheter. The angiocath is attached to a syringe and inserted into the abdomen above the pelvis on the left side, since the liver and spleen are not in this area. When the abdominal cavity is entered, a straw-colored fluid fills the syringe. Now the needle is withdrawn, so only the plastic catheter remains, minimizing the risk of injury if the patient moves. 2 quarts of fluid are removed, resulting in easier breathing and a smiling patient. Unfortunately, the fluid returns unless the liver recuperates, which is not often. A gamut of diseases can cause liver failure and subsequent ascites, but by far the most common is alcoholism. Richard was such a patient. The good sisters found Richard lying along Rue St. Joseph, Haiti's answer to the Bowery, wearing a soiled blue and white plaid shirt and shredded urine-soaked gray trousers. Richard played the part well. The week-old stubble, the randomly strewn hair, the shoeless, swollen feet, and pale, nonchalant lips all contributed to the effect. He greeted me by vomiting up blood on the floor between us. When he was done, he gave me the same nonchalant look. Richard had been doing some serious drinking. Alcoholism is rare amongst the Haitians, but then Richard was not a Haitian. He was a transplanted French-Canadian, the only white to ever come to Saint-Fith. Thanks to the rude personal questions from visitors, Richard's story later unfolded. He had married a Haitian and was living happily ever after, and she became disgusted with his drinking and physically escorted him from her premises. Since then, Richard had not fared well, subsisting until his money evaporated, at which point he ended up in the general hospital. He claimed that the Haitian doctors treated him with a novel approach, bringing him various types of Barbancourt rum and having compared the 1, 3, and 5-star varieties. It was a vast improvement over Clarin, the 20-cent a bottle rum made from fermented sugarcane roots that he had been drinking before his admission. When this method failed to cure him, they discharged him, and after several days of aimless wandering, he was found by the sisters. "How much do you drink a day?" I asked. "A bottle of Clarin." At least he was honest. "Do you have a problem with alcohol?" "Not at all." But in the same breath he continued, "I'll never touch the stuff again. Never, never, never." There was no sense in asking any more questions. There had not even been any sense in asking the initial ones. So I examined him. His skin, as well as the normally white eyes, were yellow with jaundice. His liver was tender when I pressed over it, and his distended abdomen had shifting dullness. The blood he had vomited was from his bleeding stomach ulcer, and his right foot had a huge abscess on it. Richard brought me back to my internship, the sleepless nights I had spent admitting drunks so they would not go home and use their hapless wives as punching bags. He upset me. Here in the midst of unspeakable squalor, this lowlife invaded. Everyone else at Saint-Fith was a victim of circumstances beyond their control, but not Richard. He was a self-imposed loser. In medical school, I was taught alcoholism is just another disease like pancreatitis or diabetes. It sounded sensible then, but now I no longer agreed. He had been born into a free, industrialized country and not only ended up as an alcoholic, but as an alcoholic in Haiti. Nick and Day thought it was funny, but it did not amuse me. My feelings embarrassed me. This was not appropriate thinking for a physician, but I could not change the way I felt. Unable to handle the situation, I dumped everything on Nick and Day. I had cared for this problem so many times that the treatment was forever inculcated in my mind. Put in an intravenous line. Give ampules of thiamine, folic acid, and B12. Put in a nasogastric tube and lavage the stomach. Give an antacid, drain the abscess, etc. The ascites was not symptomatic, so it did not need to be drained. I wrote down everything that needed to be done and walked away. Like most alcoholics, Richard was indestructible. He improved quickly. The jaundice cleared, the ulcer stopped bleeding, the ascites resorbed, and the abscess healed. He rapidly gained weight and self-respect, showering, shaving, and grooming his hair. He became a model patient, attending church and helping with the sicker patients. Then, as quickly as he came, he left. Several months later, a friend of mine spotted him at Rue St. Joseph. I would not let him tell me about Richard. I did not want to know. I wanted to live a lie and pretend he had not started drinking again. All the patients at Sanfi received the best care possible. Even though many were sedentary, bed sores were infrequent, much rarer than in American nursing homes. It was because the sisters took the necessary care to prevent them. To them, nursing was a vocation, not just a job. Nonetheless, working at Sanfi was difficult. A government van arrived daily to pick up the dead. Uniformed men with their poker faces carted away the bodies, the skeletons of sagging flesh that had lost their humanity long before they had died. They were piled into the van, their eyes opened widely, staring at me. They were the victims of an economic concentration camp, killed by the slow but sure genocide of malnutrition and disease. As they gazed at me, there was a glimmer of recognition in their eyes. The doctor who placed an intravenous line so they would not die thirsty. The doctor who snowed them with morphine because no amount of tender loving care could comfort a dying man in his 20s. The worst part about Sanfi is that it represented Haiti perfectly. For every patient there, given a bad food, medicine, and a brief respite, there were hundreds gallantly struggling for a gourde so they could buy something to eat. Even in death, the Haitians were exploited. The bodies could be reclaimed by their families, but at a cost of $30 over a month's wages. The government workers knew the superstitious Haitian peasants would pay because of their voodoo belief that the body had to be properly buried to prevent it from returning as a zombie. Visitors frequently came to observe. They were a diverse crowd ranging from idealistic college students to religious zealots. There were Club Med stragglers who wanted to absorb the Haitian experience. They asked me about the incidence of venereal disease, especially AIDS, then returned to Club Med. There were American nuns with their stretch pants, Nike sneakers, lacrosse shirts, and Minolta cameras, wondering why I was not smart enough to figure out they were nuns. There were the 60s leftovers in their wide-well corduroys and sleeveless t-shirts with their bald heads, thick sideburns, and bifocal wire-rimmed glasses. There were doctors vacationing from their suburban practices, making useless suggestions to which I responded with a polite smile. None of them ever stayed long. As they watched Day, Nick, the sisters, and me work, they commented how wonderful it was to see us helping the poorest of the poor. Deep down, I'm sure they felt I was crazy. Perhaps they were right. A card I received from my Belgian doctor friend best summarized the situation. On the front was an elephant on a seesaw with a bunch of mice on the other end. The elephant was suspended in the air by the weight of the mice and had a disconcerted look on its face. He wrote my name on the elephant.